Good afternoon, everyone. Welcome to this Health Foundation webinar on public perceptions of the NHS and general practice. My name's Tim Gardner. I'm Deputy Director in the Foundation's Health and Care Policy team, and I'm your chair for this event. Um, a few points of housekeeping just as we start getting going. So this is a Zoom webinar. Zoom has automatically turned off cameras and microphones for everyone who is attending but not speaking. So don't worry if you can't see yourself or other participants. This is a feature, not a bug. Also, just to let you know that this session is being recorded so that we can make a recording available to watch on our website after the event. We'd obviously love it if everyone were able to be here for the full event, but if you do need to drop off early, you will be able to catch up on what you missed afterwards. As well as putting out a video of the webinar, we'll also be uploading a copy of the slides, so they'll be available to look at after the event as well. Questions are very welcome. If you want to ask a question, please do so using the Q&A function in Zoom, not the chat function, the Q&A function. You can pop a question into there at any time. We might answer some of those in the chat as we go along, but I'll try and put as many as I can to our speakers later in the session. You can also use the Q&A function to upvote questions. So if you've seen that someone else has already asked a question that you're particularly interested in, then please give it a thumbs up, and that should increase the likelihood that it gets asked. So if we can move on to our next slide, please. I want to do a few brief introductions to the colleagues who are joining us this afternoon. So I'm delighted to be joined by some of our very talented colleagues from the Foundation's Health and Care Policy team. So we have our Policy Officer, Safia Banish, Policy Fellow Nina Hemmings, and Senior Policy Fellow Dr. Louisa Pettigrew. And they'll all be presenting findings from our latest survey of the public. I'm also really pleased that we are joined by William Pett, who is the Interim Director of Policy and External Affairs at Healthwatch England. So William's joining us to offer his perspective and to share some of the latest work that Healthwatch has been doing in this space. So if we can go to the next slide, please. So this is what we're planning to cover this afternoon. I'm going to start with just a few words to introduce the Health Foundation's work on public perceptions. I'll then hand over to Safia, who's going to present some of the latest findings on overall perceptions of the NHS and what are among the public's top priorities. We'll then go to Nina and Louisa, who are going to focus on the findings from a deep dive that we've done into public attitudes towards general practice and situate those findings in some of the latest research evidence. Then we'll hand over to William, who will offer a perspective from Healthwatch England and also has some really fascinating survey findings to share. And then after that, we should be able to devote a pretty healthy chunk of time for questions. So please do remember to use that Q&A function as we go along. So we go to the next slide, please. So I'm going to start by introducing the Foundation's work on public perceptions. So since 2021, the Foundation has been working with Ipsos to deliver a research programme into public perceptions of health and social care. Every 6 months, we survey a representative sample of the UK population using Ipsos's UK KnowledgePanel. This has more than 25,000 panelists who are recruited using what's called random probability address-based sampling, which is the gold standard in survey research. So members of the public who are invited to join the knowledge panel but don't have digital access can register, and they're given a tablet, an email address, and basic internet access to complete the online surveys. We ask a mix of different questions, some that we repeat every 6 months or every year with a view to tracking whether and how public attitudes are shifting over time and to help us make sense of what's happening in the wider health and care policy world that might help to explain why. We also include a wide range of questions that are a bit more focused on some topical policy issues where we want to gain some insights into what the public think. Alongside these surveys, we also work with Ipsos to run deliberative research with the public. So this is where we want to go into more depth and expose members of the public to some of the difficult choices and trade-offs that policymakers often face. We ran one of these before the 2024 general election. This focused on some of the big issues that we anticipated would be faced by the next government. We're in the process of finishing another piece of research, which is looking at public attitudes to how AI should be regulated in healthcare, which is going to feed into the government's National Commission on regulating AI in healthcare, where the Health Foundation is research partner. We go to the next slide, please. So our latest survey results were published just a few weeks ago in a briefing that we called Fixing the Front Doors, for reasons that will hopefully become apparent as we go through the presentation. This was the first of our surveys that we ran since the UK government published its 10-year health plan for England back in July 2025, and we held it back by a few weeks so that the fieldwork didn't cut across the autumn budget last November. But doing the fieldwork in December did mean that the survey took place against the backdrop of an early winter flu outbreak, and also it was sandwiched between two of the rounds of industrial action by the resident doctors. In this survey, we asked our usual wide range of questions about health and care, but we also did a deep dive into general practice, which is one of the things we're going to be talking about today. Go to the next slide, please. So I'm now going to hand over to Safia, who is going to talk us through some of the overall findings and broader public perceptions of the NHS overall. So Safia, over to you.
Great, thanks, Tim. So hi everyone, I'm Safia and I work as a policy officer in the team. As Tim mentioned, we run tracking questions, and this is one that we run every 6 months or every wave of polling that we do. And it's asking about the general standard of care provided by the NHS. So from May 2025 till our most recent wave in December, public views of the NHS have become more pessimistic. So 42% of the public think that the standard of care got worse, and 47% think it will get worse in the next 12 months. So it's important to note that whilst they have become more pessimistic, it is still less negative than it was before the general election. There are some breakdowns here that are quite interesting. So people who have a health problem or a disability, as well as those who used urgent and emergency care services in the last 12 months, they were more likely to think that standards got worse. And then when you look at people who used non-emergency hospital services, they were more likely to think that services got better, although it's important to note that they were still negative overall. We also ask about people's experiences of the NHS. So we pose a few statements and ask whether or not they agree or disagree. One of those statements is, my local NHS is providing me with a good service. So this one usually gives us a net positive. So here 47% agree with this statement. And again, we find that people who used non-emergency hospital services were more likely to agree with this, but people who used urgent and emergency care services were less likely to agree, and I think had a net negative overall for this response. When we ask if the NHS is providing a good service nationally, however, only 32% of the public agree, and only 15% of the public agree that their respective government has the right policies for the NHS. When you look at people living in England and Northern Ireland, they are more likely to disagree with this statement than those living in Scotland and Wales, although again, all four nations are negative overall. So for this question, we asked the public, in your opinion, what is the main cause of the current pressures for the NHS? So the top 3 responses for the general public are lack of funding, poor NHS management, and lack of staffing. So if you can see on the chart, there are notable differences according to voting intentions. So on the chart, we have the top 10 responses. The top three responses for those who intend to vote for Labour and Liberal Democrats are the same. So that would be lack of funding, increased demand due to an ageing population, and a lack of capacity in the social care system. Those who intend to vote for Conservative and Reform also share the same top three, with people using NHS services inappropriately, poor NHS management, and increased demand due to immigration. So those who intend to vote for Greens are a bit different, but closer to the public overall. They have lack of funding in their top three, as well as poor NHS management and poor government policy, and a lack of staff as their top causes. So this is another question that we ask every 6 months. So we ask the public, which of the following do they prioritise? This chart has the top 5 priorities for the NHS. So you can see here that since the general election, improving waiting times has significantly increased and is now tied with making it easier to get appointments at GP practices as the #1 priority for the public. This is followed by reducing waste and inefficiency and improving waiting times for routine hospital services. And then reducing the number of staff leaving the NHS showed no changes, perhaps surprisingly, despite, as Tim mentioned, our fieldwork being bookended by resident doctor strikes. So this is an annual tracking question. So we present the following information to the public that in order to maintain the current level of services and care provided by the NHS, we would need to increase spending. So which of the following would you most like to see? As you can see on the chart, we've got a few options here. One being increasing taxes in order to maintain this level of care, reducing spending on other services such as education and welfare, reducing the level of care and services so that you don't have to increase spend, and then none of these. So increasing taxes is still the most popular response, but over time it has seen a significant decrease. Reducing spend on other services, such as education and welfare, saw a significant increase since the year before. And there is minimal support for reducing NHS standards, but it is important to note that none of these is the second most popular option, and that a lot of the public just don't really know or don't like any of these options presented to them. So another annual tracking question we ask is about private healthcare. So we ask, at the moment, how likely or unlikely would you be to pay for private health insurance or private healthcare if you needed it? So the likelihood to use private healthcare has remained stable in recent years. So around 47% say that they are unlikely to do so. And then 14% already pay or their company pays, while 23% say that they are likely to pay for it if needed. So there are some interesting breakdowns here as well. If we combine the already pay, my company pays, with the likely, we find that people who have higher annual household incomes, those who live in the least deprived areas, those who intend to vote Conservative, and those without a health problem or disability are more likely to pick this option. Whereas for the unlikely to pay option, those with a lower annual household income in the most deprived areas, those with a health problem or disability, as well as those who used any NHS service in the last 12 months, they're more likely to say that they would be unlikely to pay. So I think now I'm handing over to Nina, who will take us through some of the general practice findings.
Great, thanks very much, Sophia. So in this 9th wave of polling, as Tim has said, we explored the public's views on general practice in greater depth. And we included questions that relate to access, use of different healthcare professionals, AI, GP earnings, ownership models of general practice, and local or neighbourhood health services. So I'm going to start with some of the findings that relate to access. And if you look at this chart on the left-hand side, you'll see that we found access to general practice continues to be a really significant issue, with almost half of respondents, 48%, reporting that they avoided or delayed contacting their GP practice about a health concern in the past year. And some groups that were more likely than the average to report this included women, people aged 35 to 44, and people with a health problem or a disability. And Safia, if you could click for me, please. That should bring up a chart on the right-hand side, which shows some of the most common reasons for this. And that includes people anticipating not being offered a suitable appointment at their practice, or deciding their condition could be self-managed or that it might resolve on its own, or anticipating that it would simply be too difficult to contact their practice. And this was the first time that we asked this question in the survey, and we don't know whether the proportion of people who delayed or avoided contacting has changed over time. But the results do seem to point to a real or a perceived problem with access that's shaping the public's behaviour. Next slide, please. Yeah, thank you. We also asked the public what matters most to them when making a GP appointment. And for this question, we used a method called maximum difference scaling that forces respondents to choose between different options and then generates a ranking. And a similar question was asked in 2021, and the results are largely unchanged. And you'll see that amidst the current access challenge, people place the highest value on having a face-to-face appointment with any relevant healthcare professional. And this was followed in second place by getting an appointment as quickly as possible, and thirdly, having a face-to-face appointment with a GP. And you'll see further down in the chart that two of the options which are links to continuity of care ranked much lower. However, it's worth noting that some groups ranked seeing the same healthcare professional more highly than the average, and that includes both young and older adults, people with a health condition or a disability, and people in rural areas. From the 1st of October of last year, GP practices have been required to keep their online access routes open during core hours, so from 8 a.m. to 6:30 p.m. This national policy aimed to help fix the 8 a.m. telephone scramble for appointments. And so in light of this, we asked the public about their preferred modes of contact. And you'll see in the chart on the right-hand side, on average, the public preferred online routes to book appointments for themselves. And this pattern was similar when we asked respondents about booking on behalf of someone that they cared for. Some groups were more likely than the average to prefer an online route, and that includes younger and middle-aged adults, so aged between 16 to 54, and people who recently used mental health services. And then in comparison, older adults and people with a health problem or a disability were more likely to prefer phone access, and adults aged 65 and over were more likely to prefer walk-in than the average. So on to the next set of findings, which are about other healthcare professionals. Given major shifts in the makeup of the workforce in general practices since 2019, we explored support among the public for seeing healthcare professionals other than a GP, so for example, a practice nurse or a pharmacist. And you'll see in the chart that 2/3 of the public supported this when appropriate. And middle-aged and older adults, people living in Scotland, and people in the least deprived areas were more likely than the average to support this. And you'll see that a small minority of about 8% opposed and 17% were ambivalent. And it should be noted that there's around 6% who did not trust that their needs would be adequately assessed to ensure that they'd be seen by the right healthcare professional. And groups that were more likely to report this included young adults and users of more than 6 NHS services in the previous year. So moving on to the next series of findings, which are about use of artificial intelligence. We know that GP practices across the UK are trialling and embedding AI tools at pace, but that regulation and policy is still developing. So we asked the public about the acceptability of using AI for a range of different types of activities. And in a nutshell, we found that public opinion is mixed, and it seems to be shaped by, firstly, the extent the activity relates to direct patient care, and then secondly, whether or not human oversight is involved. So for example, you can see on the in the red bars, where there is human oversight, most of the public find the use of AI tools more acceptable for tasks like non-clinical administration and summarising consultations. And then fewer people find it acceptable for things like triaging patients to be seen. And what's more, the survey also found some interesting significant differences between groups which supports some of what we already know from wider research on this topic. So, for example, people aged 55 to 74, and people in households earning £52,000 or more were more likely to state the use of AI for these activities is acceptable. And on the other hand, women and people aged 45 to 54 were more likely to state it's unacceptable. So moving on, given the growing debate around the future of the GP partnership model and around GP income, we asked the public what they think NHS GPs earn and what they think they should earn relative to hospital consultants' earnings. And we found that over half of the public think NHS GPs earn less than consultants. But when it comes to how much they should earn, over half the public think GPs should earn about the same. So we see there's some preference for earnings parity between these two professions. And among people who said the professions should earn about the same, the most commonly given reasons that they gave were that GPs hold broad knowledge and that consultants hold specialist knowledge in one area, and that both these professions are doctors. And of those people who thought GPs should earn less than consultants, the key reason that they chose was consultants' specialist knowledge. We also asked the public how they think GP practices are owned versus how they think they should operate, and this generated some novel insights. So when asked how they think practices are owned, 45% of the public said the GP partnership model is predominant across the UK, and just over a quarter thought that practices are mostly owned by the NHS. Thank you, Safia. And then this chart on the right shows that in reality, the majority of the public are right that the predominant model is the GP partnership model, with around 80% of practices operating in this way in England. And in reality, the proportion owned by the NHS is actually much smaller, at around 1% in England, and slightly higher across the rest of the UK, so around 6% in Scotland and Wales, and around 2% owned by health and care trusts in Northern Ireland. When we asked the public about how they think practices should operate, only 6% favoured the way that the predominant partnership model works in practice, i.e. where owners can keep profits and hold unlimited financial liability for any losses. And more than half of the public, 56%, favour practices being run as NHS organisations, i.e. where no individual makes a profit or is financially liable for losses. And this seems to be consistent with previous similar polling by IPPR on the topic back in 2020. Views vary significantly by age, household income, and voting intention, and this might reflect different ethoses or philosophies about the best operating model for general practice. So, for example, Labour and Green voters were more likely to choose an NHS-run model. Liberal Democrat voters were more likely to favour reinvestment of profits with limited liability, and Conservative voters were more likely to favour owners keeping profits with unlimited liability. Then very lastly, given the Neighbourhood Health Service is one of government's flagship policy agendas for the NHS, we asked the public which local services are important for people to stay healthy and to reduce the need for care in hospital. And if you look at the chart on the left, the public's top 3 services are general practice, diagnostic services, and mental health services. And we also found some interesting variation across different groups, which suggests that what the public prioritises depends on their stage of life and where they live and other factors. So, for example, there are some significant differences by age. We saw that young adults are more likely to prioritise financial advice services and getting into work or training. Middle-aged adults are more likely to prioritise mental health support and dentistry, and older adults aged 55 and older are more likely to prioritise GP services, diagnostic services, dentistry, community care, and social care. And the views also vary significantly by household income level, ethnicity, and region. And when it comes to sources of information on how to stay healthy, if you turn to the chart on the right-hand side, the public place the most trust in professionals at GP practices over other sources, and that includes hospital healthcare professionals and pharmacists. So those were the results, and now I'm going to hand over to Louisa, who will situate the findings in the wider evidence base on general practice.
Thanks, Nina. Okay, so building on the Ipsos polling finding, let's look at some of the wider evidence in relation to 3 areas of general practice. So the 3 areas I'm going to cover are access and continuity of care, the general practice workforce, and ownership models of general practice. So first, let's look at access and continuity of care. So providing alternative access routes, for example, 111 or pharmacy first, having larger and more diverse multidisciplinary teams in general practice, and increasing digital routes of access can widen the range of options available and can improve access for some members of the public. But it can also undermine efforts to build relationships and continuity of care, and can result in the fragmentation of care if they're not carefully designed and coordinated. And so most efforts to improve access in recent years have aimed to increase the volume and the speed of appointments. However, research consistently finds that access can't be fixed by increasing appointment supply alone. There need to be policies to improve structural and interpersonal barriers and avoiding policies that fragment care or risk widening inequalities. And importantly, there's a need to protect continuity of care. That is that relationship between a patient and a clinician, namely relational continuity of care. So what you can see here in this chart is our most recent international health policy survey of older adults in 10 countries. This found that the proportion of older adults who said that they had one doctor that they usually went to for the medical care fell 20 percentage points, from 92% to 72% between 2014 and 2024, pointing to an erosion of continuity of care in the UK. Then this is a problem. These are some screenshots of some of the evidence around this, because there's a substantial body of evidence demonstrating associations between higher continuity of care and better health outcomes, including lower mortality, reduced hospital and A&E use, and better prescribing, as well as greater patient satisfaction and clinician satisfaction, and importantly, better productivity. So the next slide, thanks, Safia. Recent research published in the BMJ, which was led by this Institute and Health Foundation colleagues, highlights the risks of policies that focus narrowly or too narrowly on increasing speed and volume of access without really thinking about their effects on continuity of care, quality of care, and equity. The research showed that expanding services across larger organisational footprints and through digital routes may widen a range of options available, but they can also undermine relationships and fragment care if not carefully designed. So the authors conclude that measures to improve access, notably digital routes, were prone to a number of unwanted consequences and did little to resolve the fundamental scarcity of appointments with a GP. However, and it introduced new forms of disadvantage and exclusion while failing to address what patients were often seeking, which was human connection and empathy with the GP they knew. So therefore, policies to reduce fragmentation of care and increase continuity of care are really important and needed. And it's also important to think that access and continuity of care are not necessarily a trade-off. You can seek to have both, and it's important to try and have both, as better continuity of care can in turn improve access due to reduced duplication, more effective care, and potentially due to better retention and better clinical satisfaction. So then on to the next topic is around workforce in general practice. So general practice workforce has really changed since 2019, with nearly a 5-fold increase in other direct patient care roles, such as pharmacists, physiotherapists, social prescribers, and other roles which are namely not doctors or nurses. And so polling suggests that the public are largely supportive of seeing other healthcare professionals where appropriate. And as a result, the proportion of appointments delivered in general practice by GPs has fallen, and the proportion delivered by other direct patient care staff roles has increased. Now less than half the appointments are provided by GPs in general practice. So as expected, the number of appointments in total per patient have also increased because there's been a rise in the workforce. But potentially the rise has not been as much as one would have anticipated, given there's been a fivefold increase in these other roles, of which there are now more of than GPs, given the expansion of these roles. And the reason for this may be that the number of appointments per full-time equivalent, other direct patient care role are lower than that provided by doctors and nurses. And there may be a number of very good reasons for this, including them providing longer appointments or undertaking really important non-appointment related activity, such as quality improvement work. But the additional roles, while they've certainly helped in general practice and are welcomed by the public, if the aim of the policy was to improve access, it does raise questions about the cost effectiveness of policies. To increase the number and the range of roles within general practice, as the data doesn't really suggest that it's freed up GP or nurse time or delivered a proportional number or rise in the number of appointments. So then looking a bit more closely at patients' GP satisfaction, at the workforce. So sadly, job satisfaction amongst GPs in the UK is lowest, is worst internationally, with GPs reporting some of the highest level of stress and being among the most likely to stop seeing, stopping seeing patients regularly. We see a picture of worsening retention. There's a growing gap between the number of licensed GPs and the number of GPs in NHS general practice. I think you need to click one more time, Safia. This means the NHS is steadily losing core clinical time. What you can see on the graph on the right is in the yellow is the number of GPs. The continuous line is those registered or licensed to practice with a GMC, but the bottom sort of dotted line shows the full-time equivalent. So there's a large gap between those licensed and those actually working in NHS general practice. And what you can see is that numbers have been pretty stable, and if you look more closely, they've actually fallen in terms of the population growth. In contrast, consultant numbers have steadily increased and kept up with population growth. So we now need effectively 2 licensed GPs to have 1 full-time equivalent working in NHS general practice. And this is estimated in 2024 to cost around £13 billion in terms of the time and cost to train somebody to become a fully qualified GP. So improving access is going to depend on better workforce planning and retention, particularly where gaps are greatest. And the gap that you can see between the licensed and full-time equivalent is largest amongst women GPs, younger GPs, and proportionally among international medical graduates, who now represent half of GP trainees. Okay, and then just looking a bit more closely at public polling, the same Ipsos polling, but it was undertaken in May last year. The public also believe that not having enough doctors is one of the biggest challenges facing general practice. This is followed by having to look after an ageing population and the lack of funding. And so although there have been efforts to increase the number, next image, Safia, thanks. Although there's been an improvement in the number of patients per full-time equivalent GP. So they peaked in July 2023 around 2,300 patients per full-time equivalent GP, which is really very high for international standards. And there has been some improvement, but there's still quite a long way to go, because levels are still much higher in terms of the workload per full-time equivalent GP than in 2015 when the data collected started. So again, we need policies to focus on GP retention. And then the last topic that I just want to look a little bit more closely at is on the ownership model of general practice. So the current partnership model of general practice offers flexibility and professional autonomy, and it's been the model since the inception of the NHS, but it can discourage existing partners from admitting new ones due to the dilution of profit share, and it exposes partners to unlimited liability, personal liability, creating financial risks and work pressures that sometimes are far too high. They can certainly deter GPs from taking on partnership roles. So what we've seen potentially as a result of this is that the proportion of GP partners has been declining, and this raises questions about the long-term sustainability of the model. GP partners now represent under half, about 45% of GPs. And so whether changes in the ownership model of general practice should be a route for reform has been a recurrent question for policymakers. It is a very complex area, and it's important to understand the public's views on this. So polling suggests that while the public are supportive of GPs earning around the same as hospital consultants, the majority seem to favour an NHS-owned model, which is different to the currently predominant partnership structure. An NHS-owned model, in theory, might help overcome some of the issues around GP recruitment and retention, but it would also bring lots of new issues, such as the cost of the shift, ownership of GP premises, which currently are mainly owned or largely owned by GP partners. There's a risk of running into deficits if hospitals took over, as many hospitals are currently in deficit. And there'll be a loss of flexibility and autonomy that many GPs hold close to their hearts. And therefore, in the long term, it might actually have the opposite effect on recruitment and retention, and it could certainly stifle innovation, which the partnership model enables to some degree. But there's very little evidence, certainly from the UK, about other models, about whether they work or not. So we should be really quite wary about potential unintended consequences of pursuing sort of a single different model, and policy makers really need to work with GPs and the public to work out how the existing model of general practice needs to evolve in order to support a more sustainable model of general practice, which will sit at the heart of what neighbourhood health services should look like. So just the last summary slide. So overall, there seems to be positive signs that some key reforms to speed up access to general practice are generally welcomed by the public. So aspects of AI and alternative routes of care, alternative health professionals and online access. But the findings also suggest policymakers urgently need to do more to strengthen core general practice. Quicker and more convenient access needs to be balanced against other important aspects of general practice, such as the benefits of continuity of care. And as neighbourhood health services develop, policymakers need to manage expectation to ensure that local leaders have the flexibility to design services that are responsive to local priorities. The focus on reducing hospital waiting lists may have shaped public's expectations for the better, but if the crisis and the problems in A&E continue to escalate, improvements in elective waiting times risk becoming a hollow victory. So overall, persistent public concerns about problems in general practice and in A&E, effectively the front doors of the NHS, mean that policymakers need to reassess priorities for health services. Thanks. So I think I'm going to hand over now to Will to give us a bit of a patient voice perspective on behalf of Healthwatch.
Thank you, Louisa, and yeah, thank you for having me. My name is William Pett. I'm the interim director of policy and external affairs at Healthwatch. And today, as a discussant, I just wanted to try and triangulate some of the findings that we've heard already from Health Foundation colleagues with some of our own research on public perceptions, particularly in relation to general practice, but I'll talk about the NHS as a whole. So next slide, please. So I'm going to cover three things. I'm going to hopefully not talk for too much longer than about 10 minutes, but want to cover, firstly, levels of public confidence in accessing services and how that's changed in recent years. I want to talk about the use of private healthcare and the implications of that, and building on from some of the earlier findings that we've heard on that. And then I also want to talk about some of the more emerging issues that we are hearing about from the public, particularly in relation to general practice. So next slide, please. So the first thing to note is that we've kind of conducted some public polling to try and test a question, which is how confident are you that you would be able to access timely care from these NHS services if you needed them right now? And you can see on the screen that we asked about a number of services across the system. So we did the same polling in 2023 and then repeated the polling last year in 2025. And you'll see that broadly there's been quite positively an overall increase in confidence since 2023, and that's been an average of a 4% increase in confidence. You'll see that pharmacies have come out on top in terms of public confidence, and that perhaps reflects the walk-in convenient nature of pharmacy services. It's obviously quite a positive picture, particularly in relation to Pharmacy First, which aims to ease pressure on GPs. And it bodes quite well for potential further expansion of Pharmacy First over the coming years. Health Watch England has done some research which highlights growing public appetite for expansion, particularly into areas like vaccinations and dermatology services. You'll see that calling 999 saw the biggest increase in confidence. That's an 8% increase on 2023, with similar increases in A&E and ambulance and paramedics. I think it's possibly worth noting that when we first did that polling in 2023, that was when we'd seen some of the kind of worst ambulance waiting times on record. So the fact that we've seen some stabilisation of urgent and emergency performance targets since 2023 is possibly explains the increase in confidence that the public has in those services. The beady-eyed among you might spot that GP out of hours services are rock bottom. Why? Well, the honest answer is that we don't really know, and I'd be interested for any thoughts from the group on that question. There's an obvious point around workforce. A major challenge facing out of hours services is recruiting and retaining sufficient numbers of GPs to fill rotas, particularly during peak periods like bank holidays. But I also suspect that the low confidence rates in out-of-hours services might also reflect simply patients' poor understanding of how out-of-hours services work. Last comment I'll make on these findings is that just across the board, we found that men were more confident in accessing services than women. And we also saw an urban-rural divide with actually some declines in confidence, particularly among rural respondents, notably in areas such as A&E. Next slide, please. So let's move on to private sector use. And here, interestingly, our findings slightly differ to colleagues from the Health Foundation on private sector use, albeit we asked a slightly different question. So we asked the public in the last 12 months, have you paid for private health or dental care service? And again, you can see on the screen that in the last 2 years, we've seen marked increases in the proportion of people that are saying that they've paid for, and firstly for private healthcare, so an almost doubling of the proportion of people paying for private healthcare, but also in dentistry, still a 10% increase on people saying that they've paid for private dental care in the past year. I think an interesting question that this poses is there an existential risk here for the NHS, particularly that kind of rising use of healthcare and dentistry perhaps starts to undermine that support base for the founding principles of the NHS. We've seen earlier stats on the declining support for increasing taxes to fund the NHS, but we've also seen in the British Social Attitude Survey some declines since 2023, particularly in the support for the NHS being available to everyone. Certainly, Health Watch England has highlighted not just the risk, but the reality of a two-tier system playing out. Indeed, actually, on dentistry, in many areas, we are seeing a one-tier service emerge in that it's private or nothing. The next slide, please. So why are people increasingly saying that they are paying for private healthcare? Well, we asked that question, and it might not surprise you to see that a top answer, and one which has increased in the last 2 years, is that waiting times are simply too long. We hear about the impact of waits from patients every day. Encouragingly, we've seen a decline in the number of patients that are saying that they're going private because they're receiving better quality of care. But we are seeing probably the biggest increase in our findings of patients saying that the reason why they're paying to go private is because it is more convenient, even if the quality of care is not better. That potentially might point to issues around administration of care and communication, which we know from patients is often quite poor in the NHS, and which potentially private providers may be delivering better to patients. So private services being more convenient is something that has really increased in the last couple of years. And then just to explain the bottom two results, we wanted to understand, if you look at that second bottom finding, there's obviously some services that people are simply not eligible for. But if you look at the very bottom finding, we also wanted to hear from patients who simply were no longer eligible for that treatment, who previously had it on the NHS. So that bottom finding, particularly that increase of 8% of people that are saying they've gone private because they're no longer eligible for that treatment, implies that we are starting to see the rationing of NHS care affect real members of the public. And we hear that particularly in regards to areas like IVF, but as I said, ICBs being given very, very difficult decisions, often about rationing of NHS services. Next slide, please. So I'll just end by talking about just some of the emerging issues that we are seeing at Health Watch England over the last kind of 12 to 18 months. These aren't issues that are front and center of our overall database, but things that we've really noticed an increase of in recent months. So there's 3 images on the screen. The top left image is there to symbolize AI phone chatbots. So this is definitely a new area of feedback, particularly in the last 18 months. And I must say that the feedback on this has been overwhelmingly negative. I should say that from a personal perspective, I know that my heart would sink if I phoned my GP practice, wanted to get an appointment, and I realised that it was a phone chatbot, and that comes through in our data. So one person told us that when I phone my surgery, an AI chatbot answers, "I'm 72 and this robot wants me to spell my name with the phonetic alphabet. How many people who are over 70 know how to do this?" So it's impossible for me to get through by phone. After 10 minutes, I put the phone down and went to the surgery the next day to make an appointment. So we're really starting to see some barriers to phone access. And you can see there, I've also included a Telegraph headline, actually from over last weekend, in which we fed some data into, which shows that this is starting to be picked up in media. The bottom left image, you'll see an exasperated woman in front of her laptop. This is in regards to online access, so particularly typically online consultation rooms. And we hear particularly from those people who feel either unable to access digital methods or not simply able to use them, who find difficulty getting a GP appointment through online consultation forms. So we heard from one person who said, "I'm 88, I don't have a smartphone or a computer. I have to just ring at 8 a.m. and hope." Now, this is particularly a problem when we get to that third image on the bottom right, which is that one method being unavailable for patients or not being able to use that method is fine so long as the practice is offering all 3 ways to contact your practice. Under the GP contract, practices should be offering access to appointments online, by phone and in person. But we know that contrary to the contract, that is not always happening. We hear stories of patients, for example, that they're told that phone booking systems aren't available and that all patients need to go via online consultation systems. As I say, that's in breach of the GP contract, but it's still something that we hear about. There have been some real improvements in access when it comes to GPs in recent years, particularly things like digital telephony systems and improved online access. We need to ensure that as much as possible, people are able to exercise their choice over booking methods. So I'll stop there. Hopefully some further data that might be helpful for the conversation, or some further questions that it raises. And I'll hand back to Tim, I believe.
Thank you very much, William. That was absolutely fascinating. We've now got some time for Q&A, but first we've got some great questions that come through in the chat. But first, I'm going to use Chair's privilege to ask a few of my own questions. So, William, you went last. I'm going to come to you first because that feels right in my head. So your chart on public confidence in being able to access timely care from the NHS, really fascinating, shows some big difference by services and also some change in confidence over time. What are your thoughts on what might be driving that recent improvement from 2023 to 2025?
So I think that in some areas there's definitely a link between performance and confidence. So I mentioned 2023 having just seen some pretty awful performance by the NHS on some of the constitutional standards. So I definitely think that as patients see that waiting times are coming down, their confidence increases. I also think that there's a link between, I suppose, perception and confidence, and you'll see that in, you have to look at the British Social Attitudes survey to see that generally patients have higher levels of satisfaction now than they did in previous years about how the NHS is being run. They might be believing that under this government there's been a stabilisation of services, and that in turn might be driving confidence in people's ability to be able to access them. The only thing I would say across these findings is that we are still operating from a very low base on confidence. I wish that we had this data going back a little bit further. We don't have it going back to 2023. But when you look at some of these services, we're still talking about a really low base of people that feel confident. So when you look at mental health services, for example, we continually hear, often from young people in particular, about being able to access mental health services. The fact that there is 80% of people saying that they wouldn't be confident to access mental health services should be a real wake-up call to decision makers. And as much as I'm trying to focus on some of the positives in improved confidence, some of these findings are very alarming.
Thank you. I mean, it's worth mentioning that we saw something a bit similar in some of our polling as well. So a little bump since the election, but still at a very low level. So Louisa, I'm going to come to you now. So one of the really arresting stats from our general practice polling was that finding that around half the public say they've delayed or avoided contacting their practice about a health concern. You're a practicing GP as well as a researcher. So what's your perspective on whether this is what you might expect to see as a matter of course, or how much of this reflects genuine barriers to access? Do you see some of this in your clinical practice day to day?
Yeah, it's a really good question, and it is really a very striking figure. So I guess the first thing to say, it's the first time that we've asked this question, so it's unclear over time whether this is more or less than in the past. So it's hard to say. It's a snapshot. And then thinking about the reasons why people who think that they have a problem to contact their GP may or may not do so varies by their characteristics, as Nina highlighted. So actually women, those aged 35 to 44, and those with a health problem or disability were more likely to put off care. So that's quite concerning. And then, decisions to access care influenced by how people perceive their own condition, how urgent they perceive it, societal expectations, worry if their address might be perceived as dismissed, or the context, for example, COVID or other disease outbreaks. And there's evidence to suggest that a closer relationship between patients and their GP can help encourage health-seeking behaviour. When we look at other surveys who have asked similar-ish questions, it can range anywhere between 19 and 66% of the public choosing to put off care. I think one of the big things that we don't know is actually what proportion of those patients ended up having to represent or presented elsewhere, such as an A&E or another place, and what proportion had an adverse outcome. So, and just very quickly, from a clinical perspective, a lot of things self-resolve, and a lot of things that you see in general practice resolve by themselves. So from a clinician's perspective, it's maybe not that surprising that, you don't need to contact a GP, because there are, most things do go away. But the worry is that the small proportion that are serious are not presenting, and therefore presenting in a delayed way. Yeah.
Lovely, thank you. So Nina, I'm going to come to you now. So you presented some findings on public's priorities for what services to include in the new neighbourhood health service framework. So I know you've also been looking at the framework that's been coming out of NHS England. So what do you think so far about how that framework compares to the priorities we found in that polling?
Yeah, thank you, Tim. That's such a good question. And Louisa and other colleagues, we've been mining the NHS neighbourhood health framework for a while now. And for colleagues on the call, this is the NHS England and DHSC plan to deliver neighbourhood health services specifically in England. So having looked across the framework, there is some positive alignment between at least the top 3 priorities put forward by the public and what's in the framework. So if I just run through them in turn, the public's top priority was access to GP services. And there is a strong but quite narrow focus on this in the policymakers' framework, in that it requires NHS organisations to improve rapid access to general practice services. But there's actually very little in the framework on other things like continuity of care and other measures of general practice. I think the second most important service the public prioritised was diagnostic services, so access to X-rays and CT scans, things like blood tests. And again, the framework does refer to this, and it talks about how NHSE will map out existing community diagnostic centres and aims to increase these over the next 3 years. So some positive reference there. And then the third priority for the public was on mental health. And again, the framework refers explicitly to piloting, I think they called them 24/7 neighbourhood health, mental health centres. And this seems like it could be a really promising model to better support people with severe mental illness and reduce mental health crises and deliver all of this much closer to home and outside of hospitals. And that's currently being evaluated. So in a nutshell, there does seem to be some alignment between what policymakers have proposed and what the public want. But I think the much trickier next step will be how to actually find the resources to deliver on these. And that's something the framework sort of neatly sidesteps and doesn't quite address.
Wonderful, thank you. So Safra, I'm now going to come to you with a question that I wanted to ask, but also came up in the Q&A. So that's a nice bridge to get over into some of the questions that have been coming up there. So you presented a chart with that shows that improving A&E waiting times is now virtually tied with improving access to general practice and the public's priorities for the NHS. Is this just a seasonal effect? I mean, we know the fieldwork was done just as winter was getting going last year, so maybe that's just the time when there's people thinking about A&E a bit more. What do you think?
Yeah, thanks, Tim. I think that's a very valid point, especially given all that media about the super flu and everything that was happening at the time. But I think when you look at that chart, that priority hasn't changed much since we asked the question in May 2025, which definitely is not winter. So that it is something that is very important to the public. And I also mentioned some of the breakdowns in the data, which showed that people who had used urgent and emergency care services in the last 12 months being more pessimistic about standards of care, and also, like, more importantly, about their local NHS service, which showed a net positive for the UK population, but was actually majority negative for those who had used that service. Another interesting breakdown was when we asked the public about their number one priority. People in the West Midlands and in the northwest of England, they were more likely to pick this as their number one priority. And when we had a look around, we found that during the time that we fielded the survey, there were reports of overcrowded A&E departments, there were spikes in seasonal viruses, and even like critical incidents declared in these departments in these areas of England. So this data is very much grounded in people's real life experience of that service, and not just what they're seeing in the news, which shows that it is a serious problem in the system and not just a seasonal one. Thank you.
Great, thank you. Right, so we're going to start getting into some of the great questions that have been put in the Q&A now. So Simon Lovegrove asked, NHS frontline services work well, but the NHS seems to struggle with strategic thinking. And I work in other countries. Some of the more successful that are overtaking the UK on health outcomes have realised that health is multi-sectoral, starting with where and how we live. So our ageing society requires a change in hospital planning and more out-of-hospital services beyond traditional primary care. So what's the opportunity for better strategic thinking? So Will and Nina, I'm going to come to you for your takes on some of the specific issues that this raises. But just before you do that, a bit more broadly from a Health Foundation perspective, I think we would agree, and advocating for that broader approach to health that looks beyond healthcare has been an increasingly important part of our work over the last few years. We're just about to launch our new 5-year strategy, which will continue to emphasise the importance of looking at the wider determinants of health and take a health in all policies approach. So do watch that space for more from us. But Will, over to you first, and then I'll go over to Nina.
Yeah, I really love the question. I wish I could upvote it myself. I think that the premise of the question is absolutely right. I think one element of us moving towards that more multi-sectoral approach can be seen in, I think, how the NHS treats the VCSE sector. And I think that, unfortunately, the VCSE sector is still considered a lot of the time to be a kind of irritating younger sibling rather than a core strategic partner. And I think that often we give lip service to the VCSE sector, but often don't build them into decision making. So, part of an example of that, I think, is that in an ideal world, at the moment we have the NHS app, which is being positioned as access in your pocket to NHS services, but really we should be considering how we can link people better into some of the VCSE sectors, VCSE services that already exist in their area. The fact it's called the NHS app is problematic. The app should be much bigger than just simply launching the NHS. And I'd love to get us to a point where we have much better asset mapping of community and voluntary services for people, so that we don't have to continually encourage patients to go to the NHS as their first port of call. So that's just one part of what is a much broader question. But I really agree there's a long way to go if we're to have not just an NHS view of health, but a much more multi-sectoral.
Shall I chime in on that, Will? And I agree, I really love this reflection from person in the audience. Just thinking about the neighbourhood health framework that I mentioned earlier, you can see there are some efforts by national policymakers to bridge across with the work in other departments. And that includes Ministry of Housing and Local Government, Department for Education. So you can see there's some political will to join the dots and think beyond a medical model of care and think outside of the realm of the NHS, and how NHS organisations might better partner with, as Will said, the voluntary sector, local government. And elsewhere, we're seeing greater devolution of, I guess, responsibility for health in all policies. So there's health and wellbeing boards, there's new mayoral health commissioners being developed. And I guess ultimately it will boil down to how permissive central NHS England and DHSC can be with local areas, to having the right level of autonomy to design their local services to better meet the needs of their local populations. And for anyone who's interested in some of that Ipsos Murray survey data, there's a whole minefield of really interesting breakdowns where we can see, for example, I think it's in the Northeast, people from that area prioritised voluntary sector services and support. People from minority ethnic backgrounds prioritised financial advice services and getting into work and training. So there's loads of evidence as to how local partners can work better together on those wider determinants of health.
Thank you, Nina. So Louise, I'm going to come to you. As you might expect, we've had a number of questions about general practice. So I'm just going to throw a few at you and hope that you can cover as much as you can within the next few minutes, which I'm sure is not at all like being a GP. Someone asked about the number of GP appointments having increased quite dramatically from 5 to 6 per day to over 60 per day. But what are the reasons for this? Great question about what's the evidence? Is there any evidence that continuity of care improves outcomes? Do we have a sense of the number of appointments per person being due to there being multiple professionals working in practice at the same time, rather than a single one who might have previously dealt with multiple aspects of care? Are non-GPs more or less likely to refer into secondary care or commit to more diagnostic tests? And has there been any work done to look at why GPs leave the NHS and choose to go into private work? So over to you to decide what to take. And Will, if you've also got any ideas on that from your work and the patient perspective on that, do please chip in.
My goodness, Tim. Okay, I'll try. I won't tell you. I can only deal with one problem at a time. Um, yeah, I saw the comment about the rise in requests for appointments. I think inevitably, the online access has really opened the gates, the front gates, to general practice, because what we were having before was effectively a form of rationing that you'd have to navigate the 8 a.m. scramble on the phone. And it was often who persisted the most, who got there and got the appointment. So I can understand that for GPs, that that doesn't happen anymore, and they can potentially have unlimited requests online submitted by the public, by their patients, Monday to Friday, 8 a.m. till 6:30 p.m. And I guess GPs are trying to work out how to do that. They've got to introduce triage systems, as we heard from Will. Some GPs are trying AI bots and so on to try and manage that demand, but obviously there's risks and potential unintended consequences with that too. With regards to continuity care, there's loads of evidence about how important it is. It's associated with a reduced mortality, reduced A&E attendance, reduced hospital use. I know the question was specifically about cancer. I can't remember there's something specific about cancer, but there's a whole list of sort of improved clinical outcomes around continuity of care, and also productivity, so things being more efficient, less duplication, and so on. And better patient satisfaction, and potentially also better clinician satisfaction. Somebody also asked, does it have to be with a GP? And the answer is no. Of course, you can have continuity care with a nurse or with another healthcare professional, but you need to have that relationship and repeated appointments with them to develop that relationship and reap the benefits of continuity of care. What else about referrals? Whether different roles do more or less referrals. I don't know what the evidence is just now, but I think the theory would be that if you're slightly less qualified, or you have a less comprehensive scope of work, then maybe you will be more risk averse and therefore request more tests or refer more easily. But the evidence about referring more or less is not clear cut. Sometimes referring more is important, for example, to prevent cancer referrals, whereas referring less is not a good thing either. So it's quite nuanced around there. But inevitably, I think the key thing is if you don't know the patient and you don't know their history, then there's definitely a higher risk of you ordering more investigations or repeating things just because you don't know the patient's history and you don't know things as somebody who does know the patient. And then about leaving, there's lots of evidence around why healthcare professionals, GPs, leave NHS general practice. Specifically about private medicine, I think there's probably more of it around now. I think after COVID, there was a rise in online consultations, GP services, private services. So there's probably more of a market, so an alternative for GPs to go and work privately. I'm certainly seeing that amongst peers. But obviously many of the push factors, burnout, stress, frustration, feeling unsupported, and so on, a reason that push GPs out of clinical practice.
I think that Louisa has covered it expertly. The only thing that I would add is just on the continuity of care question, which is a really good one, and I absolutely support what Louisa has said about there being a really strong evidence base for the benefits of continuity of care for patients. The problem is, I think, that waiting times have got so bad in recent years, and we have a framework of targets that are all specifically around waiting times, that you can understand why the public has started to see quicker access to an appointment as the overriding factor that should be prioritised rather than continuity of care, and how we start to rebalance that over the coming years and communicate clearly with the public about the benefits of continuity, I think is going to be a real challenge.
Great, thank you both. Safia, I wanted to come to you with a question about, do any of the findings suggest public support for or awareness of the importance of prevention? What do you think?
Thanks, Tim. So 2 waves ago, this would have been like a year ago in terms of the polling. So November 2024, we asked the public about whether or not they support the government's 3 shifts for the NHS. So those 3 shifts being the focusing on preventing sickness, not just treating it, moving care from hospitals to communities, and making better use of technology. So out of the three of those, the focus on prevention was actually the most popular one. So 86% of the public supported that one. In that same wave of polling, we also asked about public health risk factors. So those would be risk factors around tobacco, on alcohol, on obesity, and what level of like government intervention people will support in that. And the public again are quite supportive of quite increased government involvement in addressing those. And then in this most recent wave of polling, we asked, assuming the NHS budget is not increased, which of the following do you support? And is it prioritizing community-based services or easier access to hospital care? And we found that the most popular response was prioritizing community-based services. There was a bit of a decrease in the response from the last time we'd polled that question, but it is still a majority that support prioritizing community-based services. So I think I would say, yeah, there's a lot of support for prevention, and I think a good bit of awareness about it too.
Thank you. Well, sort of just to put you on the spot as we sort of edge towards the end of our time, what does Health Watch England's work on prevention say at all about this subject? What's your view on it?
I think it comes back down to the point I made previously, which is that I think that things have got so bad in terms of access that I think the public's first thought is our service is going to be there when I really need them, when I find myself in a crisis situation. I think that some of the messaging around the prevention agenda is quite currently far from the public's thinking. I think it's absolutely essential that over the coming years we take the prevention agenda much more seriously, but I think that we have quite a long way to go to make the public feel that they are involved in that conversation and that they understand what prevention means to them in their local area. Because at the moment, as I said, there's a long way to go to bring some of the key actors around prevention into local conversations about the wider determinants. And I think that's a real challenge that ICB is going to face over what's going to be a difficult few years.
Brilliant, thank you. So I'm afraid we are now coming to the end of our allotted time. So I think that's probably all the time we have for questions. We could probably have gone on quite a lot longer. As I mentioned earlier, a recording of the webinar will be available to watch on our website in the next few days, along with a copy of the slides that were presented. So feel free to use and share those if they're useful. The Health Foundation also has a weekly newsletter which brings together our latest work and advertises events like this. So please do subscribe to that to be kept up to date. And I just want to finish off by thanking everyone for taking the time to join us today. Know how busy everyone is at the moment. So really do appreciate people taking an hour and a quarter out of their day to join an event like this. In particular, I want to thank William for agreeing to be on our panel, not least given that you arrived hotfoot from giving evidence to a parliamentary committee and can now hopefully take a very well-earned break for a few minutes to have a cup of tea or something. Thank you to Safia, Nina and Louisa from the Health Foundation for presenting so well and giving us your insights. Thank you also to Sashil, Caroline, Lavina, Sarah and other colleagues who've been working behind the scenes and have really made this event happen. So all it leaves me to say now is goodbye, and I hope you enjoy the rest of your day. Thank you.